couch potatoes. They are sitting in and just changing the remote and watching the TV or playing on the iPad. The continuing rural to urban migration of the Indian population is another reason which contributes to this obesity because in the cities with overcrowding, there's less opportunity of moving around, and many children are crowded in one room. Those are the living conditions. This also contributes to it. So this is just an example of the usual intake distribution in which 2.5% of the group have intakes below the ER. So a population, the energy and nutrient requirements should be based on ER, but in a disease-specific situation, the energy and nutrient requirements should be tailored to that specific condition, and when that child ultimately starts recovering from the illness, your yardstick to compare it with is the RDA first. And your requirements ultimately for that child should meet the RDA. As the child completely recovers and goes back to the community, you can go back to the ER requirements. That would be a very practical way of looking at this. Now, moving from public health interventions to clinical nutrition. Now, I'm just providing an overview. All these three options of feeding are available to any particular child. The first option, which is the easiest to achieve, is the oral option. And when a child is not able to take too much or is vomiting when you're giving major meals to a child, it's better to split the food to 5 or 6 different small portions throughout the day. That itself may work. However, if you find that the oral requirements are not meeting the energy and nutrient needs, then you can pass a tube and feed the child by accessing the gut through routes other than oral. This is called enteral, which I'll touch upon. When the gut cannot be used for whatever reason, or there's a clear contraindication to using the gut for feeding, you can use an alternative route outside the gut, which is called parenteral. For all practical purposes, this refers to intravenous feeding, which could be to a peripheral or central access. When you look at the types of enteral feeding, when you're starting feeding in a child who has not been fed for some time for whatever reason, it's better to start, and if you're feeding into the small intestine, because small intestine can't take large volumes like the stomach. So it's better to give it as a continuous drip, very much like an intravenous infusion, but give it through the nasogastric or nasoduodenal or nasojejunal. These are the various methods, and you give it as a continuous drip, ml per hour, you calculate. Bolus feeding is at fixed intervals of 2 or 3 hours, you give a fixed volume of the feed. Intermittent feeding is a bridge between continuous and bolus feeding. Many centers move on to intermittent feeding, where they give continuous feeding for a few hours, then keep no feeding for some time, and then again give feeding for some time before transitioning on to bolus feeding. Now, modes of enteral nutrition delivery can be through a tube passed through the nose, either exiting in the stomach, which is called nasogastric, or it can be post-pyloric feeding, where it's called nasoduodenal, or in specific situations where you need to give the feed in a pre-digested form, or where there are issues related to absorption, you may have to deliver the feed further into the intestine in the jejunum, where it's called nasojejunal feeding. Now, if you want to plan long-term feeding, you can also use the endoscopic method of introducing the tubes either into the stomach or the duodenum, where it's called percutaneous endoscopic gastrostomy or percutaneous endoscopic jejunostomy. The surgeons can directly place the tube also with an open surgery, gastrostomy or jejunostomy. Both methods are preferred. Now, the endoscopic technique may involve less invasion. Coming to parenteral nutrient delivery, you have peripheral venous access as well as central venous access. If you want to use a higher concentration of dextrose, above 12.5%, or use a higher concentration of amino acids exceeding 8%, please never use the peripheral line, because the thrombophlebitis incidence with a higher osmolarity, with both the high amino acid infusion concentration as well as a higher concentration of dextrose will cause